Right. So the paper that I'll be sharing this evening is entitled Comparing Cardiovascular Outcomes and Costs of Perindopril, Enalapril, or losartan-based antihypertensive regimens in South Africa, a real-world medical claims database analysis done by some local heavyweights in the hypertension space based in multiple places, University of Cape Town, Stellenbosch University, as well as colleagues from WITS. So it was really a collaborative effort. So in terms of the background and rationale, it's well known that 82% of all hypertensive patients reside in low and middle income countries. So we're talking about in excess of 1 billion patients on this side of the world with hypertension. And it was shown in 2016 that approximately 45% of men and 48% of women here in South Africa had hypertension. So presumably now the fractions are even higher. Unfortunately, only 22% of men and 29% of women who have hypertension in sub-Saharan Africa are on treatment. And what's even worse, only 9% of men and 13% of women on treatment are adequately controlled. So lots of people not on treatment, and of those on treatment, very few are adequately controlled. There have been efforts to improve things. The International Society for Hypertension has recommended a single combination pill comprising drugs such as angiotensin-converting enzyme inhibitors or angiotensin receptor blockers plus calcium channel blockers as the first-line treatment for most patients, unless there are good reasons not to use these drugs. And in 2024, only very few patients should be on single-agent therapy. It's only 3 groups of patients that should be on single-agent therapy. Number one, low-risk patients that have grade 1 hypertension, or very, very elderly patients, and we're talking about people over the age of 80, or frail patients. Everyone else really needs to be on combination therapy. And the best combination therapy is fixed combination therapy because it improves adherence, and particularly if it's once a day therapy. So what's not known or what's not clear is differences in class or molecule-specific effects between the renin-angiotensin-aldosterone inhibitors have not been conclusively demonstrated. So it's not clear whether the cardiovascular benefit is class-specific or it's due to the molecules themselves. And this is something that's an ongoing debate at the moment. So since individual ACE inhibitors have different clinical properties, theoretically, there could be molecule-specific effects beyond and above that of BP lowering. And in fact, an analysis that was done in 2009 by a group from Stellenbosch suggested that perindopril may be associated with superior cardiovascular outcomes compared with the other ACE inhibitors in hypertensive patients. Just to remind everyone about the mechanism of action of these drugs. Pull up my laser. So renin from the kidney cleaves angiotensinogen into angiotensin 1. And this is then acted on by the angiotensin converting enzyme and converted to angiotensin 2. And it's angiotensin 2 that then has the end organ effects, including enhanced sympathetic activity, vasoconstriction, activity on the adrenal gland to produce aldosterone, which then goes on to lead to salts and water retention. The other effect of the angiotensin converting enzyme is to cleave bradykinin into inactive peptides. So in terms of the level at which these RAS inhibitors work, ACE inhibitors obviously inhibits the actions of angiotensin-converting enzymes, so more upstream effects, leading to inhibition of the downstream effects of angiotensin 1, as well as potentiation of the effects of bradykinin. So all the positive cardiovascular effects of bradykinin, such as vasodilatation. And increased bradykinin levels in some patients leads to that dry, irritating cough that sometimes patients complain about. And the ARBs work downstream, preventing the action of angiotensinogen 2 on its receptor, on the AT2 receptor. And it's been shown that these molecules behave differently in the clinical space. For example, perindoprol has been shown to have a duration of effect that lasts 24 hours. And critically, it covers this period that's been shown to be associated with an increase in myocardial infarctions and stroke in the early hours of the morning. So it provides 24-hour coverage. The other drugs don't really do so. They fall short of this 24-hour coverage. The only drug that comes close is telmisartan. So theoretically, there could be molecule-specific effects that lead to clinical differences in the activities of these drugs. So the research question that the group came up with is, are there clinical and cost benefits associated with the ACE inhibitors and ARBs that are commonly used in South African patients using data from a large medical insurance claims database? So the study design was that of a retrospective observational study of medical claims data. They used the Discovery database, and Discovery has 39% of the market share of medical aid patients. And that's why they chose Discovery. So they looked at patient-level claims over a 5-year period spanning from January 2015 to December 2019, and they analyzed these claims to measure clinical and cost outcomes according to the type of antihypertensive regimen received. So they scanned the database, looked for ICD-10 codes, and because there are varying ICD-10 codes for hypertension, they used what they call a disease episode grouper to put all these ICD-10 codes together. And this disease episode grouper also linked claims to various providers, general practitioners, specialists, hospitals, and various other facilities. And they also used the World Health Organization anatomic therapeutic chemical codes, which is simply a way of identifying which organ systems a particular drug in a database acts on, so that they could identify cardiac-specific drugs. And they also used a mortality indicator to identify mortalities during the study period. So the inclusion criteria were basically patients taking perindoprol, losartan, or enalapril, either alone or in combination with other agents. And they needed these patients to have an adherence rate based on prescriptions that were filled versus the number expected. So if patients did not have good adherence, they were excluded. And patients needed to have stayed with Discovery over the 5-year period. So if they switched medical aids or fell out of medical aid completely, they were also excluded. There were 2 outcomes. There was a primary outcome, which was a composite of the risk-adjusted event rates of having at least one claim for myocardial infarction, ischemic heart disease, heart failure, or stroke within the 5-year study period. The secondary outcome was the risk-adjusted all-cause mortality rate and risk-adjusted rate of hospitalization for any of the composite outcome events, both expressed as the rate per 1,000 people over 5 years. The cost outcomes were defined as the total cost of claims paid in South African rands per life per month that were linked to a hypertension or a related condition as a comorbidity, including aneurysm, diabetes, stroke, ischemic heart disease, heart failure, myocardial infarction, renal failure, hyperlipidemia, vascular dementia, and arrhythmias. So this is the consort diagram. So they screened just over 108,000 patients in January of 2015. And of these, 56,000 were in the Perindopril arm. And in the Perindopril arm, they excluded just over 23,000 patients for those three factors, being non-adherent, leaving discovering, or changing their medication. And at the end, in the Perindopril arm, they had 32,857 patients. The enalapril arm in the middle had 25,464 patients. And after excluding patients for the same criteria, they had 13,939 patients on enalapril. And in the last arm on the far right, the losartan arm, they initially had 27,324 patients. And after excluding 10,631 patients for the same reasons, they had 16,693 patients in the losartan arm. And these patients were then compared to each other for outcomes. This table describes the demographic characteristics, the health plan information, as well as the clinical history at the index date. Just want to point out that when they compared Perindopril to losartan and Perindopril to enalapril, the patients were very different in terms of risk index. The patients in the Perindopril arm had a higher risk index, which means they had more comorbidities and were at higher risk. They differed in terms of age, they differed in terms of gender, they differed in terms of health plan type, they differed in terms of comorbidities, all comorbidities except for heart failure and aneurysm and vascular dementia. So this is not the sort of baseline you want when you're starting a trial, because you want your groups to be evenly matched so that you know that you're comparing apples with apples. When you have such vast differences, you need to do a lot of statistical adjustment to account for the differences and minimize the bias that may arise. But this is something that's well known to plague this type of study where you're analyzing medical claims in retrospect. All right, so in terms of other results, this is the breakdown of the primary outcome, the risk-adjusted combined cardiovascular event over the 5-year period into the various components. So in total, when they compared Perindopril to losartan, Perindopril had 205 claims per 1,000 patients, compared to losartan, which had 221 claims per 1,000 patients, and this was shown to be statistically significant. When they compared it to enalapril, there was also a statistically significant difference in favor of Perindopril. When they compared Perindopril to losartan, the differences were driven by stroke. There was more stroke in the losartan arm, and ischemic heart disease. And when they compared Perindopril to enalapril, the differences were driven by stroke as well as myocardial infarction. So in summary, it was really, the differences were driven by coronary artery disease, either chronic or acutely, and strokes. This is the same data represented in the form of Kaplan-Meier curves. So again, perindopril outperformed both losartan and enalapril when it came to the composite primary outcome. And here at the bottom, this panel shows the mortality outcome, the secondary outcome that they looked at. And it showed that when perindopril was compared to enalapril, there was a mortality benefit in favor of perindopril. But when they compared it to losartan, there was no mortality benefit. They were equivalent. This is the cost outcome result. And it showed that the risk-adjusted costs in South African rands per life per month in each treatment cohort over 5 years. The average cost for perindopril was 1,342, whereas that for losartan was 1,466, and that for enalapril was 1,540. And the differences between perindopril and the other two groups in terms of costs were found to be statistically significant. So in the discussion, the things that were summarized as the important findings by the researchers are the following. Firstly, while patients receiving perindopril were younger, there was significantly increased cardiovascular risk in this group based on the greater frequency of pre-existing ischemic heart disease, the higher insurance coverage, and the higher risk index values compared with patients receiving enalapril or losartan. Okay, so patients with on perindopril tended to be at higher risk. Number two, the primary outcome of the risk-adjusted rate for a claim for cardiovascular events was lower in the perindopril treatment cohort, as was the rate of first occurrence of the composite outcome. Number three, perindopril-based regimens were associated with significantly better cardiovascular and cost outcomes over a 5-year period. And lastly, they said there was a significant mortality benefit relative to enalapril, but not losartan. And they compared this study to a similar study that was done in Taiwan. They compared even more ACE inhibitors in the Taiwanese medical claims database study. They had drugs such as perindopril, ramipril, and lisinopril on the one hand, and they had captopril and enalapril on the other hand. And patients that were on perindopril did better than patients that were on captopril and enalapril. And there have been a number of meta-analyses. There was a big Cochrane meta-analysis that tried to look at all these drugs. No significant differences were found when they looked at these drugs. But interesting, there was another meta-analysis that found that ACE inhibitors compared to ARBs have better outcomes in terms of myocardial infarction and renal failure, whereas ARBs tended to have better outcomes for stroke. Okay? So it's quite interesting that there are these variations depending on the study population that's considered and the type of study that's done. Niskia did say at the beginning that this is an observational study based on medical claims, so there will be multiple limitations. I just want to highlight what I thought were important limitations. So firstly, this was an observational study. No matter how exciting your findings are when you have an observational study, the data is really hypothesis generating. If you want to test the efficacy of drugs, you really need a randomized control study. And it's a randomized control study that will get policy change and guidelines to change. They made a mortality benefit claim, which I thought was an exaggeration. because the mortality outcome was a secondary outcome. In studies, when you have a primary outcome and a secondary outcome, your design and your study is powered for the primary outcome. So if your primary outcome is positive and your secondary outcome is also positive, your secondary outcome can only be hypothesis generating. You cannot claim that it was a conclusive finding from the study. You actually need to do another study powered on that secondary outcome for you to say it's a conclusive finding. And thirdly, the analysis is based on claims data, and it's been called real world. But it's really, in a way, a play on words. I mean, we don't know anything about what a real patient in this study looks like. For example, we don't know the average blood pressure of the participants. We don't know anything about their ethnicity. We don't know anything about their body mass indices, smoking status, etc. So, the term real world may be a bit of a stretch, but nevertheless, it is data, and there is value in this data. We've talked about the fact that claims data is not designed for research. It's dependent on coding. It's meant to, it's meant for reimbursement purposes and not research. But like I said, it is data and there is value. And I think the researchers did a lot of analyses, including sensitivity analyses. And, it does appear that there might be molecule-specific differences or effects of these drugs that lead to cardiovascular benefit over and above that of class. So in conclusion, in data from a large South African claims database, there appears to be molecule-specific differences in drug effects within the ACE inhibitor class, and there appears to be a cost benefit with the use of perindopril compared to losartan and enalapril. And the authors concluded by saying further studies are warranted to confirm these results in a broader South African population, which may have significant implications for the choice of therapy in patients with hypertension. And they pointed out the fact that patients who are with discovery may be different from patients with other medical aids and patients who are in the public sector. And so we would actually have to repeat the study and replicate the findings in various population groups to apply these results to, the entire South African population. Personally, in terms of these drugs, if I have a choice, if I'm at my practice and I see someone with perindopril and it's not a Black patient in whom, the use of an ACE inhibitor is less efficacious, I'm more likely to pick perindopril based on its pharmacological effects. That 24-hour cover for me would be important to protect them from early morning events. If I'm in the state sector, I'm going to use whatever is available. If they have perindopril, well and good. If they don't, I'll use the alternatives that are available. Thank you.
Thank you so much, Dr. Chisala. I'd like to open up the floor for any questions, if there are. Dr. Chisala would be happy to answer them.
Dr. Chisala via Niskaya. The likes of, thanks for a most informative and insightful talk. The likes of enalapril, lisinopril, should they be by default used on a BD basis?
Yes, they should be used on a BD basis. Yes, because they don't have 24-hour coverage. If you give them once a day, at some point they will expire. And if you want 24-hour coverage, you'll need to give them BD. And the only issue with that is patient compliance to taking medications. It is easier to take medication once a day than twice a day.
So, to your knowledge, within the public sector, enalapril is on code. Are they using it BD?
It depends where you go. I've practiced in the Western Cape in public, in states. I've practiced in KZN in states as